And now Dr. John Krakauer from Johns Hopkins. And as Glenda said, everyone has a very lengthy resume. So I will just tell you that he's going to talk to you about dancing with dolphins.
Okay, hello everybody. I'm not a morning person, so I want to thank Glenda for inviting me. This is my first time here, and also for Access Circles, Carol Lee and Lynn for co-hosting me. Okay, so let's get started because I don't have very long and I have lots to say. All right, I'm going to advance the slides myself. This is where I'm at, Johns Hopkins. This is our website. I always show this. Please follow us on Twitter. That's the most important thing for any neuroscience lab. And you can also find all our publications and, most important, media appearances. Okay, so I'm talking about stroke today. So for those of you who aren't familiar with what stroke is, it's when a part of the brain is deprived of blood and oxygen and dies. 800,000 people a year have a stroke in the United States. There's somebody having a stroke every 40 seconds. It is the leading cause of disability. It is by far the leading neurological disorder. And unfortunately, between 1 in 5 and 1 in 6 of you in this room will have one. Even though Aspen may, beat those odds with all the healthiness that I've seen around me. It's quite extraordinary. Anyway, the problem is that after stroke, even though there are new ways of treating the clot, and I run the neuro-ICU and the stroke unit at Hopkins several weeks of the year, once you've had your stroke, it's the leading cause of disability in the US, and we do not have a good rehabilitative treatment. And the last thing I'd like to say, for the women in the room, twice as many women die of stroke than they do of breast cancer. Okay, so stroke is sort of an absolute epidemic, in a sense, but people don't know that much about it. So these are sort of 10 patients who've had strokes. We now have imaging abilities to sort of identify the stroke very quickly. And these are patients that I actually put in a database when I was at Columbia before I moved to Hopkins. And essentially, these are patients who've all completely paralyzed down the other half of their body. Where it's white is where the stroke is, and everyone here is paralyzed down one half of the body. And the question are two questions. Can you predict the ones who are going to get better? And can you do anything to make them get even better, or do something about the ones who we predict will not get better? Okay, and it's a big problem. Now, unfortunately, in the US and in other countries, after you've had your stroke, and for reasons which will become readily apparent in a moment, what we do is we put people in hospital rooms in the first 2 to 3 weeks where they're alone 85% of the time, and alone 60% of the time, and immobile 85% of the time. So you sit in your luxurious room watching the Weather Channel, basically squandering a unique period of plasticity, which I'll tell you about in a minute. So in other words, for all of you see these gleaming hospitals and the names on their plaques, unfortunately, the rehab that you will get after your brain injury, whether it's TBI or stroke, is medieval. Okay. Now, we published a mathematical relationship. You don't need to know too much about this. A number of years ago, it's been reproduced several times. The only point I want to sort of make about this is that there is a predictable relationship between how much you will recover from your brain injury in the vast majority of patients, except the ones who have severe injury. And the main point is that this mathematical relationship actually implies that what we do for a patient when they're in their hospital after stroke has no impact whatsoever. That there's an endogenous process doing all the work, and we're basically standing by and watching. And just so you understand, what rehabilitation today does, with an average length of stay of about 12 days, it shrinks every year because of economic considerations, is to teach you to cope with what you have left. It's not trying to repair what's been damaged, it's saying we'll teach you to use a walker, to transfer out of bed, all very commendable things, but they're not repair, they're coping. Okay, whereas this relationship that I'm showing you is a repair relationship that's going on in the background, and what we need to do is to learn how to piggyback on top of the repair process rather than just focusing on coping. So I'm just going to show you, we do at Hopkins and at other places a sort of quantitation of movement. This is one way we do it. People sit at a table and they have an air sled and they make reaching movements like around a clock like this, so all of you would make nice straight arm movements. This is just a way to quantify movement without you being able to cheat with respect to compensating. You can't move your trunk, you can't find another way to get the task done. This is really probing how well you can move. Okay, and the one thing I want to tell you is if you use this kind of quantitation of movement and you track people over a year after stroke, and you find a way to mathematically sort of describe these trajectories. So basically, this is what people after a stroke look like, even with gravity removed and friction. They still have an enormously difficult time making accurate movements. And of course, the million-dollar question is, how do you get from here back to there? Okay? And basically, you can quantify mathematically how far you've moved from this kind of performance back to normality. And basically, this is a graph showing that mathematical relationship, and all you need to see is that any improvement happens from here to here, very little afterwards. It's all over within 4 weeks. So you have about 4 to 5 weeks to actually repair. And remember what I told you, 2 to 3 of those weeks, you're sitting alone 60% of the time, non-moving 85% of the time in this window. So it's being utterly frittered away. Okay? Now, we also look at rodents, and this is not a very good slide, but basically Kolben Weishaw, some scientists in Canada, made a very nice point that reaching in rodents has a lot of similarities to reaches in humans, so we can learn quite a lot from rodents despite the evolutionary distance. This is a little mouse that we've trained, and I mean, I bet you didn't know they had such cute little hands. Look at that. So this is a mouse that, doesn't have very good table manners. It would rather use its tongue, but we make it not possible. So it goes, okay, I'll reach then. And then you can train the mouse to be quite accurate. Okay, and it's so cute that we give it a stroke. And this is where you give it a stroke. This is a cross-section of the mouse brain. This is its motor cortex. And basically you can induce a stroke. And then what happens afterwards on this task is you can train the mouse before on reaches. It gets to about 60% accurate reaches, and then it plateaus. You then give it the stroke, and of course, the behavior plummets. Okay, and then what we're going to do is we're going to sort of rehabilitate the little mouse, okay? And we're going to do the same kind of neglect that human beings suffer from currently in US hospitals. So we're going to wait a week, and then we're going to start training it on the task. And as you can see, even 3 weeks of intense training every day, we can't get it back to where it was, okay? What about if we do this again, but we don't wait? We go right away within a day after the stroke, all right? We're going to guess that in a mouse, that window that I said was about 4 or 5 weeks, in the human might be even shorter. Back to normal, all right? So that means that we are proving that there's a critical period, a sensitive period of enhanced responsiveness to training that we could piggyback on, okay? So basically what we're saying is that if you delay, you don't get as much bang for your buck with training. If you go right away, you get more. We need to do something about this delay. Now, this is the crazy piece. If it's true that stroke induces a time-limited period of sensitivity to injury, then paradoxically that implies that if you've waited too long to be trained intensely after your stroke, then obviously the best way to treat you is to give you another stroke. All right? So that's what we did in the mouse model. We said, let's wait again too long. We train, and basically they're no longer responding to treatment. And then what we're going to do is we're going to give them another stroke right next door to the one they've had. And what you'll see is they'll get worse, obviously, because you've given them more stroke. But then you're going to see something quite dramatic. Back to normal. So basically what this second stroke has done has reopened this window of plasticity that closed previously. All right. Now, obviously, at Hopkins, nor anywhere else, I hope, are we going to do this to our patients. I think what we're saying here is that there is a principle that we need to exploit. Okay? This is just a control, so you can read about this kind of notion here. I will, in the interest of time, skip it. So the question is, without giving people another stroke, how are we going to exploit this sensitive period? What are we going to do? Now, are there drugs or brain stimulation effects that we can do, or can we enhance with enrichment? I haven't got time today to go over all the ways with drugs, with brain stimulation, what could potentially prolong this window and enhance it. I am going to talk about enrichment. So it turns out that if you take a mouse or a rat and you put it in a very fun environment, in other words, you put it in an environment with its friends, with toys, with challenges, in the absence of task-specific training, they get better. But this is our hospital rooms right now. Right? We're in a cage, basically, a luxurious cage, but it's a cage nevertheless. So the question you should be asking yourself is, how do we do this for humans? What's the human equivalent of enrichment? Because as I said, you've got this window that's closing. All right? These are growth factors that are turned on and then turned off. All right? So what would an enriched environment for patients look like? Well, the answer, we think, was hiding in plain sight, which was animation. Now, I haven't got time to go into the history of Disney and the reasons why it is so pleasurable for us, but the key aspect, and what the early animators at Disney in the 1920s realized, was that we love to watch bouncy, real movement. What they actually called it the illusion of life. Okay, so we thought, how are we going to sort of exploit this pleasure in watching bouncy, cool movement and bring it into treatment? Now, it also turns out that all of us in this room, and this was a study done by a colleague of mine in England, Daniel Wolpert and his colleagues, they basically showed that all of us live in a statistical cloud of everyday movements that look like these donut elliptical clouds of statistical movements. So all of us are doing this. I'm gesturing right now. You eat with a knife and fork. You're on your computer. So basically, many, many tasks of everyday life live in this statistical cloud. Okay? Now, if you have children, children babble. Right? They're just statistically exploring their environment, and eventually they converge on successful movements. So the idea was, not only are we going to have people sort of be in this Disney childish, wonderful world, but we're going to try and make them babble as well. Okay. Now, finally, so what we're converging upon is the final piece of the puzzle, which is how are we going to make people babble and be in a sort of Disney-like feeling movement? And this is Omar Ahmad, who's actually the head of the technology group that is doing what I'm about to show you. And this was us working for a couple of years with dolphins at the National Aquarium in Baltimore. Because what we would argue is dolphins are admired because they are intelligence injected into movement. So what we want to do is to make you feel like you're a dolphin. So this is me in the robot with Bandit, the simulated dolphin that we researched after years with the dolphins at the aquarium. This was actually an article in National Geographic, and people just sort of captures the immersive feel of being in the exoskeletal robot, plus with Bandit the dolphin. And Bandit is a simulation, and with the robot, you actually become the intention of the dolphin, the lights are off, and you begin to actually swim and babble, chasing fish with your arm, not even aware of your own arm. It's no task-specific training. We just want you to live as a dolphin in that statistical cloud of everyday life. This is the team. And, you know, the kind of team that you need, and I think this is a point I'd really like to emphasize, to do this kind of work where you combine robotics, art, animation, gaming, neuroscience, brain stimulation, needs a very unusual conglomeration of nerds. Right? So Omar Ahmad worked as a Disney Imagineer. Kat is a full-time animation artist. Pramit was most valued programmer for 3 years at Microsoft. And Kevin Olds got his PhD in robotics at Hopkins and then joined us. Now, this is a very unusual kind of team, and medical schools are going to have to change in terms of accommodating these kind of people rather than having them disappear off to Silicon Valley to make the iPhone 9 or whatever it is. Okay, so now I'm just going to show you a video to finish of what this experience is like, and then we'll stop. Could we play and the first one's presentation. And maybe put the lights down a little bit and turn on the sound. No, it's that one. It's right there. No, the one behind it. Just click on the, you don't have to reduce anything. Okay, and press play. Play there. And can you fill the whole screen? So this is what the patients see in the trial that we're currently doing. This is the robot. So currently patients are enrolled within 5 weeks of their stroke in that window, and they spend 3 weeks being a dolphin twice a day. It's incredibly intense. This is not an animation, it's a simulated dolphin. So first you have to, this is a graduate student demonstrating, and you have to chase fish. And then it gets harder. The sharks can eat you too. This is actually a patient playing in this particular video. So I'll stop there, and the trial is ongoing. Thank you very much.